everyone. Myself, Dr. Lalit Sharma. I am a medical oncologist at Manipal Hospital's Jaipur. And a topic for today's discussion is role of CGP in lung cancer. But we would be keeping this very basic. We would be discussing CGP, the role of CGP in oncology per se, and in a broader term, how CGP stands in our oncology practice at this point in time, and in brief about its current role in lung cancer also. So most of us would rather agree that genomics or molecular pathology is an evolving field at this point in time in oncology, and there is a lot to learn for all of us. This is in true sense wherein the research and the clinics have come together to improve the outcomes in oncology. There is a huge flood of data, and there is a lot to do, a lot to understand, a lot to imbibe, and a lot to put to practice. And I believe the key here for a successful implementation of this very important tool of genomics to improve lives is going to be a two-way street between a molecular pathologist and the clinicians. So they are going to help us identify the driver mutations, the basic pathology which is driving these disorders, and probably in turn, after implementing that information in our patients, the subsequent responses, the subsequent kind of clinical scenarios which are going to develop, until unless we convey it back to them, I don't believe we would be able to use this very important armamentarium in our very important weapon in our armamentarium to fullest. Now, to look at the basics, basically, as per the WHO definitions, if we see, genetics is basically the study of heredity. But we are rather more interested beyond that. We are actually interested in the genome itself. And genomics is the study of the genome, and it is defined as study of genes in our DNA and their functions and their related techniques. So basically, to start with, the genes, the genome is something which has the potential. This is kind of translated into transcriptome, that is the RNA. Now, this is somewhat akin to implementation strategy. Now, this implementation strategy further translates into the proteome. That is, the vivid number of proteins are expressed after this RNA is kind of implemented. And these proteins, these are the actual kind of tools which affect the function or the phenotype. And taken all together, these proteins, these lipids, these sugars, these nucleotides can be considered as the metabolome. So this is the final outcome product, and these are the ones which affect the cells in vivid manners. And unfortunately, in patients who suffer from oncological disorders, they give messages or they lead to events into the cellular structure which makes these cells divide and kind of proliferate in uncontrolled manners. So this is the basic science, this is the basic concept behind the cellular molecular pathology. This is what we are trying to look into. There is a huge kind of information available in the genome, in the transcriptome, which ultimately leads to manifestations in the form of proteome or the metabolome, which we are trying to understand. So, how does genomics basically help us in improving the outcomes in the oncological scenario? The first and foremost thing which this particular science helps us is in implementation of personalization of therapy to its core. Why? Well, it's not gone are the days wherein we were treating most of the cancers as garden variety of cancers. any lung carcinoma would be treated with platinum compounds. Any breast carcinoma would be treated with anthracyclines or taxanes. Now is the era of personalization of therapy. The idea is to look for what is the molecular pathology which has actually led to this particular disorder in this particular patient, and what is the best possible targetable agent we have which we can introduce in this particular patient to improve the outcomes in all manners. First and foremost, once you target your therapy, that is, you optimize your treatment based on this data of what is the molecular pathology, you are able to get rapid responses. You are able to get deeper responses, more sustainable responses, and the most another fortunate aspect is with much fewer adverse events because these particular targets won't be available on the normal body cells. So this is somewhat moving towards probably an ideal scenario where we want a drug to be very effective, very early to respond, very deep to respond with minimal side effects. That is what we have been trying to kind of achieve from the very beginning in pharmacology. We probably are at least a step towards that particular scenario. So one is it gives you a better diagnosis, not just define a particular carcinoma as a garden variety carcinoma, but precisely say we talk about lung carcinoma, a precise pathology will be defined. That is EGFR exon 20 insertion mutated lung carcinoma. That precise. That then it is going to give us a better prognosis. We very well know by now that an EGFR mutated is going to behave separately, then an ALK mutated, then a non-mutated. So we'll be able to convey the patient and the family a far better prognosis. There will be fewer adverse events for obvious reasons, and we will be able to optimize the treatment selection not only at the upfront scenario, but whenever there is a progression, if you are able to further identify what further mutations led to these particular resistance mechanism. Say, for example, in a lung carcinoma, the patient has developed a T790M mutation. The patient was started on the first or second generation TKI. Then we very well can switch the drug to a third generation TKI, such as osimertinib, and we can achieve further kind of improvement in the overall survival and the quality of care again. Improved access to therapies, like we have already discussed, and better disease monitoring also. Say, for example, in CML, we are able to monitor what are the log reductions in the BCR radial copy numbers and whether the patient is on the road of a healthy recovery or not, whether we need to intervene early because if the responses are not up to the mark, we probably would want to intervene even before this is actually manifested as clinical progressions, and effective clinical trial participation also. So basically, we have moved from a protocol-based medicine to a data-driven healthcare, volume-based healthcare to a value-based healthcare, and as we discussed earlier, the one size does not fit all, and we are trying to personalize the therapy as much as possible with the help of genomics. And to implement this, the next generation sequencing is the major tool which has made this possible. We have had an idea of what we are trying to do, but to implement that, next generation sequencing is the tool which gives us sequencing of thousands to millions of DNA molecules simultaneously. It also helps in a high throughput approach with the capability to sequence multiple individuals at the same time, which has helped us in improving the kind of turnaround times also, costs also, and important and irreplaceable tool currently in genomics NGS is. So, what is the advantage of NGS over the other kind of available tools such as quantitative PCR? So, it provides provides the single base resolution. It has single input of DNA and RNA. It is able to screen multiple genetic alterations in a single reaction from a single tissue. That is, you do not have to run a sequence of kind of individual mutations one after the other. Okay, this was negative, maybe let's try another, maybe let's try like we have been doing in MPN reflex panels. We are, if we didn't find any PCR region, let's go for the next possible KLR or n number of mutations that we know of. We can run it in a single go. So this optimizes the use of tissue also. We most of the times are grappling with lack of tissue. Uh, the patients for obvious reasons are not going to be very keen to go for repeated biopsies. So the optimization of the tissue use can very well be achieved by daughter-based NGS panels. It also provides information on the immunotherapy genomics also, signatures also. That is, not only are analyzing the genes for individual mutations, we are also able to see what is the tumor mutation burden, whether microsatellite instability is there or not there, and depending on the that we are able to take decisions whether immunotherapy is going to help us in this particular scenario or not. It also gives a better picture of tumor heterogeneity, superbly sensitive and specific for biomarker detections. That is, it is replicable. Uh, Subsequently, when you are going to do it in an individual patients or in various patients, you are able to replicate the results very sensitively and very specifically. And results are reproducible with superior accuracy. So if we talk about the close contender, that is the Sanger frequency or the quantitative PCR, the benefits with PCR is that is it is a very familiar workflow. We have been using it for long now as compared to NGS, and the capital equipment is already placed in most of the labs. Whereas NGS, it is basically a growing concept, evolving concept. The initial kind of establishing costs are quite high. The technical know-how is limited. The trained personnel are limited, which probably is not that with a quantitative PCR comparative. But the challenge is with PCR is it can only interrogate a limited set of variants. It will only give the answers which you are asking for. It would not discover. Virtually no power of discovery is there. It is only going to run a limited number of kind of it is going to give you limited answers, those which you have already kind of decided which you want out of this test. And there is a low scalability. Whereas in the targeted NGS, there is a higher discovery power. Where we have now larger and larger panels, which are going to give us a large amount of data. Not always that it is a boon. Many a time it perplexes us to interpret that particular data. But yes, there is going to be always a chance of discovery that you would find some answers which you were not actually asking and which have therapeutic implementation also. That is, you are able to target those particular mutations which you probably were not thinking or were considering very rare in that particular scenario, but the outcomes uh, get affected very significantly, and a higher sample throughput is possible. Now, the challenges here are it is less cost effective, especially if you are running smaller panels, limited number of targets, that is less than 20. And the time consumption for smaller panels is also very high, that is, the TAT is also very high. So coming to NGS in lung cancer, I'll be briefly addressing that, and then we'll be moving towards the question answer session. The lung carcinoma is one particular scenario wherein the principles of genomics has very well been studied, and not only been studied, has been implemented both in research and in the clinics. There were days a few decades ago wherein almost all lung cancers were treated as a garden variety of cancer, and we used to be kind of offering most of these patients cytotoxic therapy, be it platinum based or taxanes. And then came an era wherein the concept of small cell and non-small cell was introduced. Gradually, we were able to differentiate further histological variants such as squamous, non-squamous, large cell, and adenocarcinoma. But then came the revolution, and the revolution was molecular diagnostics came into picture. We were able to identify in a significant chunk of patients the molecular pathology which was driving that particular oncological disorder. The most common one was EGFR mutations, followed by a large number of uncommon ones, such as comparatively lesser common, such as AL, cross, and there are a lot many lesser common ones, such as MET, RET, NTRK, and a lot many of them. And moreover, now we have data towards the PDL1 expression, which helps us classify these patients into PDL1 expressors and non-expressors, which to some extent help us understand what are going to be the responses towards immunotherapeutic agents in these particular patients. So, importance of the biomarker testing is pretty well known to most of us. And it is, what shall we say, molecular alteration superhighway. There are n number of mutations which are feasible in varied combinations. We are aware of say 8 to 10, and new are being added as we speak, and it's basically a molecular superhighway. Now, another question which comes to our mind in our clinics is whether we should go for targeted panels or broader panels. Now, I would kind of classify my choices into two scenarios. One is a resource ample scenario, wherein resources are not in question. We have everything at our disposal. I believe the larger panels or the broader based comprehensive genomic profiling rather than panels is the answer for two reasons. One is it gives the chances of discovery are far more here. We get answers which actually we probably were not looking for to start with, and can improve outcomes. Moreover, this helps us build data also. What I was talking about initially was it has to be a two-way traffic. The genomics people letting us know what is ailing the patient, what are the various mutations which are there, and us clinicians going back to the molecular pathologist by letting them know what the these particular this particular information and the subsequent actions led to what clinical scenarios were there, what were the responses, whether uh, a lot many scenarios, the answers might be obvious. Okay, this particular mutation, this particular drug, but most of us can recall scenarios wherein we tried to do what was in the book by the book, but the responses were not that mutation. So if that information goes back, that is imbibed into the data bank in coming years or maybe in a decade or so, we will be with every passing day, we will be more wiser to how to utilize these particular this particular flood of data, this particular kind of information. When it comes to resource restricted setting, I believe the restricted panels are probably the answer because if the resources are very restricted, we would not like to exhaust our tissue and efforts and resources into areas wherein the data is more of research purpose and not of therapeutic purposes in that particular patient. So, as we have already discussed, limited gene tests fail to identify targetable, novel, and tissue agnostic genomic alterations. The most common or the targeted kind of panels would identify only the mutations which you are actually asking for. There are a large number of uncommon EGFR mutations other than exon 20 insertions, and their number is growing day by day as we speak. There are a large number of rare mutations in the common driver gene scenario. So, one is that, okay, we were looking for an EGFR mutation. But an NGS probably would help you identify even the rarer mutations in these common mutations which we see in non-small cell lung cancer. The data varies from place to place, study to study, and EGFR mutation is considered to be anywhere between 30 to 50%, especially in our Asian population in various studies. But a conservative idea would say that 30% of the patients harbor EGFR mutations. The most common of these, majority of these are exon 19 deletion or exon 21 point or L858R mutations. But then comes a significant chunk wherein there are atypical, uncommon EGFR mutations. Percentage wise, these might seem to be very less, but if we talk about sheer numbers, especially in highly populous states like ours, these numbers could be very high. And some of these are sensitive to traditional EGFR inhibitors, but many of these might not be. And if we are able to identify that what particular mutation these atypical or uncommon mutations are there, we might be able to tailor our therapy furthermore also, where this is where NGS comes into play. Like for the sake of example, exon 20 insertions. These are kind of resistant to the traditional EGFR inhibitors, and we would like to consider newer approved drugs such as Agreement in these particular situations. Moreover, the other targetable uncommon mutations are G79X, S7, 768I. There is a huge long list. We have, as clinicians, have now further started referring to databases rather than memorizing each and every one of them. Look into those databases, what particular mutation we have discovered and what has been the responses with the various therapeutic agents in these particular mutations in other patients in the data bank itself. And here comes again the importance of letting your molecular pathologist know what were the responses in your individual patients so that this data bank can grow day by day and we are more kind of mm, wiser day by day to understand what these mutations and their combinations lead in clinical scenarios. So in these particular mutations, what we have seen first and second generation EGFR TKIs probably would not work that well. Afatinib has shown anywhere around 60 to 70% responses in these particular patients, and osimertinib, though the number was very less in this particular study, but the overall response rate has been anywhere around say 40 to 70%. Now, coming next to the next common mutation, that is the ALK mutation. Most of, not all ALK mutations would be similar. They would behave very differently, and there are more than 90 different ALK fusion partners which we have identified so far, and there is accumulating data to understand that there probably are more, and they might behave very differently. And if we talk about rare mutations in the uncommon genes in non-small cell carcinoma, this list is ever growing, be it ROS1, RET, ERA, NTRK, MET, or 2, or PIP3CA. Though majority of the lung cancer is driven by EGFR and ERK, but these are also very well identified. Most of us would have patients on one or two rare patients on these particular mutations if we leave aside NTRK, which is quite rare. So this is what the scenario has changed in non-small cell lung carcinoma in the last decades, starting from cytotoxic therapies evolving into the targeted therapies, and now combinations of the targeted and the chemotherapeutic agents, introduction of immunotherapeutic agents pretty early, either in combination with chemotherapeutic agents and some trials also going on for combination with targeted therapies also. Thank you so much for a patient hearing, and I would like to hand over the floor now to the organizers to take things forward.
Thank you so much, sir, for this wonderful session. It's a great summary of all the important aspects of how molecular oncology or molecular genetics can help in NSCLC management. Um, can we now move on to the discussion part of it, particularly the take-home messages that we have from today's session, in the interest of the ongoing students to their final exams? Hello, sir. Can you hear me?
Yeah, yeah, I can hear you. Kindly go ahead. Any
Yeah.
questions are quite welcome. Rather than questions, I would like this to be an interactive session wherein we can
Huh.
understand from each other.
Yeah.
Dr. Vidya, I want to impress one particular thing that many
Uh,
times it is being kind of seen as if we order a test, a particular result has been kind of conveyed to us, and then the clinician goes ahead with whatever available data is and chooses a particular kind of say therapeutic agent and goes ahead like that. I wish gradually we need to understand that it has to be a two-way street. There has to be a continuous conversation between a molecular pathologist and the clinician to understand these data better. Uh,
yeah.
your comments on that?
Yes, sir. I completely agree with you, sir. In fact, I understand the clinicians are very much occupied and they have so many hundreds of patients, and it might be difficult for them to remember. But as a protocol, which is already followed in the West, we do it on emails, and if possible, we communicate with the clinicians from the beginning of the testing. In importance of tumor content assessment, particularly in lung cancer management, when we have tissue as a limiting factor at times after finishing multiple IHCs, suppose we are having very minimal tissue available, and if the patient is not eligible to go ahead with another biopsy due to some physical conditions or several other factors, then a discussion at that point of time with the clinician becomes very important. It has to be done promptly within first 2 to 3 days time after verifying the tumor content. There is a big role of molecular pathologist along with the clinician to decide how to take it forward. If there is a suboptimal tumor content, how much suboptimal as low as what we can go, and what are the pros and cons of the suboptimal tumor content. The major drawback with suboptimal tumor content would be you might end up getting false negative results because adequate representation of tumor cells with adequate heterogeneity may not be there. So for this, one important aspect that I want to share with all of you, and we have cited this information in many of the articles, and we have seen this from earlier studies also. That is, in some places it is 10%, and many places, many laboratories say a minimum cutoff is 20% of tumor. But the important take home message for all the clinicians and for the laboratory professionals is 20% is a percentage and it is a very relative term. Considering these are core biopsies and very, very thin threads of tissue is available, having 20 cells in a core is also 20% out of a background of 100 cells. That is not sufficient to call it that it is eligible for an NGS. So what is eligible for an NGS? It's not 20 cells or 20%. So what is eligible is we have to have a minimum of 500 malignant cells in a given H&E section, which is a two-dimensional representation of the tumor tissue while it was embedded into the FF. This is what really gives us adequate DNA that will help us in giving the best results, doing the 200% of the effort, the whatever NGS can get out of it. One has to have that much number of cells present in the tissue. Suppose it is less, like 200, 250, then then comes the call. If it is 20, 30 and all, we should outrightly reject it. There is no point in doing. But suppose it is somewhere near 200, 250 cells in a given H&E slide, then the choice is, as we go deeper into the FFPE block in the 3 dimension, there is a possibility that we will be able to procure more number of tumor cells. Then is the role of the discussion that comes in between pathologist and clinician. Can we completely deplete the tissue available in the block? With the consent of the treating clinician, we can take that material and attempt for testing to provide the best possible results for the patients. We do it very often in our labs, sir, when there
Probably
is
the
a
message
limitation.
which we are trying to convey is it's not
Mm,
the number of cells, it's not the percentage which matters. It is
mm,
about the bulk of DNA which we can extract out of viable DNA, which we can extract out of that particular specimen to help us
mm.
study the genome. Is it so? In
Yeah, bulk
simpler
of
terms.
the DNA, and very importantly, nowadays the tumor cells has to be written down in a given H&D examination. That becomes like in, if you see the PDL1 reports, they say we have counted 200 immune cells around it, or they have looked into a background of a tumor and immune cells, put together 200 cells, out of which how much is immune percentage and how much is tumor cell percentage for PDL1 staining. Similarly, one has to write how much is the percentage of tumor cells present and number of tumor cells present.
So,
And one more point to add, sir. There is something called as NGS derived tumor percentage, which is being adopted in many laboratories which are CLIA certified laboratories in the West. What that does that mean is, suppose in an NGS report, there are, example, 3 mutations. EGFR 23%, TP53 is, let us say, 30%, and then RB1 is, for example, 17%. So the largest of all the mutations, 23%, that is considered as the true representation of the tumor clones which have been part of the assay. So definitely there is 23% tumor cells present in the NGS, because that is the largest variant allele fraction that we could arrive at from that NGS report. So it is called as NGS derived tumor content fraction. So which is like you are actually getting a quantitative measure. Suppose you got EGFR 5% and you got 23% TP53 and you got 17% RBM. Still, it is called tumor content is 23%. It is just that there are many malignant cells present, but not all malignant cells carried EGFR mutations. The majority of them, almost all of them, carried TP53. Some of them carried RB1, but a very small proportion of them were the ones who carried EGFR mutations. So this is the inference that we draw, and it directly correlates to what you feed in. If you feed in enough tumor cells, you get the best results.
so probably what we are getting a message is that
Uh,
NGS also helps us understand the tumor heterogeneity also.
uh,
So
yeah.
another issue which is very pertinently kind of here addressed in this question I can see in the chat box is that say we have a targetable alteration as well as a PDL1 expression of more than 50%. Now, what therapy do we go ahead first? So before I answer that, so there is a very another important aspect here that there is going to be sometimes very perplexing data coming to you. That is, you will be able to see multiple molecular pathologies playing in a single tumor. Then you'll have to take help of your molecular pathologist to address which is actually which they consider actually to be the driver mutation out there. As far as this question goes, I hope the answer is slightly easier here, because in the sense that you will have to see what particular targetable alteration you have seen. Say, for example, there are two scenarios. One, you found that the targetable alteration is ALK fusions with a PDL1 expression of more than 50%. Whereas the another scenario is that you found that it was PIK3C mutation with a PDL1 expression of more than 50%. Now, in the first scenario, obviously, I have a mutation which is known to be kind of a driver mutation, which has decent number of targetable agents available with us and are known to have really good responses, good response rates, very well tolerated, really decent, I would say more than decent overall survivals and progression-free survivals. I would like to go ahead with the targetable therapies first. Now, in the second scenario, wherein you are able to find a PIK3C mutation, wherein we know that the targetable agents which are available to that particular mutation probably are not that efficient, or are drugs difficult to handle and are not going to give you very practice changing using PFS and overall survivals. Considering the patient's condition, I might kind of go ahead with immunotherapeutic agents first. So most of the times, barring individual mutations, I would prefer to go for the targeted therapies first, achieve as much as of PFS and quality of life parameters as possible, and on progression, if there are no further line of therapies available, go for immunotherapeutic agents. I hope that answers your question, Dr. Abhishek. So I had this another question from Dr. Minal, and is NGS possible from liquid biopsy or CTC? I believe yes, and I believe Dr. Vidya will be in a better situation to dwell on that particular question. Dr.
Yeah.
Vidya, over to you.
Yes. So NGS is possible on liquid, robust method, or rather the most well established and highly reproducible method is the liquid biopsy by ctDNA, because you get tons of ctDNA from plasma, and by and large in lung cancer it has been really very well established from multiple studies, and our own studies from India, we have shown more than 97% concordance between tissue and liquid biopsy ctDNA NGS at baseline stage 3B stage 4 disease NSCLC. So the ideal, if you want to look at comprehensive molecular profiling or targeted profiling or even a hotspot profiling, ctDNA remains the gold standard, or rather the best possible choice when it comes to liquid biopsy. When it comes to CTCs, although there are many studies which are uh, established and as well as upcoming, the robustness, when you say robust, it should be 100% foolproof in terms of giving very less false negative results, and reproducible, meaning today you took 7 ml blood and you got 1 CTC, tomorrow also you have to get 1 CTC. And suppose that single CTC you profiled and you looked at mutation, you should be getting the same mutation. That kind of experiments, or rather testing, has not been done at the research level in a large setting to prove that CTCs are the right way to go. So CTCs still remain more of only prognostic biomarker rather than considering them for genomic profiling. The best alternate is ctDNA in place of tissue.
So I would
Sir,
like to
yes.
add here. So
Uh,
the answer to your question is NGS possible from liquid biopsy? Yeah, it is possible. But as very well said by Dr. Vidya, you have to understand that it has its own challenges and pitfalls also. The message should not go as if liquid biopsy can be a replacement to the tissue biopsy.
Mm.
The tissue biopsy remains till date gold standard for your initial
Mm.
diagnosis and all.
Mm.
Two scenarios wherein liquid biopsy can be helpful is one is if there is a lack of tissue to start with and you are looking for answers, then probably liquid biopsy will help you. Second, probably Dr. Vidya would agree, is monitoring of the responses, wherein
Yes.
now this is an evolving concept now that monitoring of responses might be feasible with liquid biopsy or circulating tumor DNA, though it's not an established phenomena so far. So we should not consider this to be per se a replacement of tissue or core biopsy. The idea should be to establish it on the tissue biopsy itself, but in scenarios where that is not feasible, yes, that is probably an answer with its own pitfalls. I hope that answers Dr. Anjan's question, which one is better, a core biopsy or a liquid biopsy also.
Diagnosis remains on tissue, and after diagnosis, if there is a challenge with tissue, then liquid can be used. Better core biopsy or liquid biopsy. Oh, there is nothing called better between core and liquid. Core, it means the gold standard for diagnosis. Dr. Lalit sir has already described that.
Yeah, totally agreed, Dr. Abhishek, that they can definitely improve our understanding of the mutation landscape if done together. So again, as in the initial part of my talk, I said that fortunately or unfortunately in the Indian scenario, we have both the scenarios. One is where we are resource ample, there is no restriction to the resources, and you could do whatever you wish to under the sun. So in those scenarios, yes, in conjunction, it's going to give you a better understanding of the molecular landscape. But in resource restricted settings, probably we'll have to go ahead judiciously. So, anything else? Dr. Vidya?
So, in the in any further thing that we want to add, sir? The somatic and liquid comparative biopsy is quite effective for any type of
Okay, so
cancer.
there is this one question: is somatic and liquid comparative biopsy study quite effective for any
Uh,
cause?
so this is
I
in similar to what has been asked in the first previous question. Comparative means together. That's what we understand, right?
Yeah, I believe that
Um,
in conjunction, probably the landscape would be better. To be very honest, I am not able to get
um,
one.
comparative liquid biopsy is or otherwise called as combined liquid biopsy, combined tissue and liquid biopsy profiling is becoming a norm in some hospitals in many countries now. However, cost remains a major concern to do it together. Advantages are you will get the most comprehensive information about the disease, and it is most applicable primarily in metastatic setting where you already have the imaging data that shows that there is metastatic disease. There it has a very good value addition by doing combined profiling. In an early setting also it has an important role. Suppose liquid biopsy turns out to be positive in a very early setting, alarming signature for the clinician that although disease remains localized, it is actually not localized. It is already into circulation. So that is one important message the clinician would get when in an early setting. Um, That's one major, value add. And tissue biopsy is a local sampling event, whereas liquid biopsy is a holistic or a global sampling event. Therefore, you get a true representation of the molecular picture of all the metastatic locations. So one cannot humanly not possible to go and pick up tissue representation from multiple metastatic location. So in such a scenario, liquid biopsy becomes a value addition. I think in the Indian scenario, what percentage of patients respond to targeted lung CA therapies? Is this vastly different from Western population? Sir,
Now, Dr.
sir,
Anvil, unfortunately, the precise answer to this question is we don't know. And the reason for that is most of our data is not compiled, not organized, not reported. So, to date, most of what we know about majority of the drugs, their response rates, their adverse effect profiles is derived more from the Western data. There are only limited institutes which are reporting, compiling their data. So, and moreover, the response rates would depend on what particular mutation you are talking about, what particular therapeutic agent you are talking about. Say, if you are talking about an EGFR mutation, the response rates are far different as compared to the ALK fusion scenario. Even in one particular scenario, say EGFR mutation, it would depend on what particular targeted therapy you're talking about, whether you're talking about the first generation TKI, second generation, or the third generation. Gefitinib would have a different response rate as compared to osimertinib, both in the Western and the Indian populations. So I believe there is no single straightforward answer to it. It would vary from agent to agent, mutation to mutation. Yeah, but there is a decent chance that we might not be behaving the same as Western population as we don't behave in the landscape also. We have more of EGFR mutations as compared to the Westerners or for that matter, Alkan also. I believe that addresses most of the questions and the kind of salient features of comprehensive genomic profiling. Dr. Vidya, can should we wrap it up now?
recently there is one article. Let's see. Germline testing in non-small cell lung cancer. Um,
So my take, Dr. Kaushik, is again you'll have to divide your patients into the resource settings. If resources are not an issue, definitely you should go ahead with it. And in case you want to be judicious about it, probably the answers would be you might be considering using the resources very judiciously. But for academic purposes, yes, that helps us understand the genomic landscape far better. Uh, Vis-a-vis somatic analysis done, only somatic analysis done. So, Dr. Vidya, shall we wrap it up?
yeah. So please clear me immunohistochemistry and NGS method. Immunohistochemistry looks at the final end product of any mutation, that is protein, any protein change. Classical example is HER2 amplification in breast cancer. NGS gives you information at DNA level that HER2 is amplified and there are 10 copies, 20 copies of HER2 examples. Whereas IHC is the gold standard or the ultimate effect. It is like cause and effect. In NGS, you know, at the DNA level, there is amplification. In IHC, you are seeing a strong staining boundary of every tumor cell that explains that there is increased expression of HER2 receptors on the breast cancer cells, which you are visualizing in microscopy. That gives much more confidence that highly expressed, and this is the driver which is driving the disease, and it is the true target that can be targeted. So by doing NGS, you miss the morphology. By looking at morphology, you don't get to see the finer picture of the genetic alteration. So they both are complementing each other, or rather both of them have their own important roles to play. I hope it explains what you would like to know, Dr. Ranjan.
Yeah, it definitely does, Dr. Vidya. Thank you for that elaborate explanation.